we are going to be looking at the criminal justice system and blue light services. So hopefully you've all seen a copy of the agenda. So without further ado, we're going to start off with our colleagues from the Saturn Centre, and I'd like to introduce Robin and I'm going to get your name wrong again, I'm sorry, Trisha. Robin and Trisha, thank you, who are going to tell us a bit about their service. So over to you guys, thank you.
Yeah, hi there everyone, good afternoon to you. So as Jane said, my name's Rob James and I am the male outreach stroke engagement worker at the Saturn Centre. And this is my colleague Trisha Burnett, who's one of our forensic nurse examiners here. And as Jane said, we're here this afternoon just really to tell you a bit about ourselves and how we operate and support people following a rape or a sexual assault. So we are based at Crawley Hospital and we're known as the Sussex ARC. So yeah, if we could have the next slide, please. We can do that. Can we do that? Thank you. So basically there is a SARC is the emergency service for anybody following a sexual assault. Each county in the UK has a SARC. And fundamentally, we all work pretty much the same, although there are some sort of operational differences purely based on commissioning and such like. We're here this afternoon very much obviously representing Sussex and how we work in Sussex, but equally it's important for you to know that there's a similar, if not identical service all around the UK. And on the slide now is just the details of some of our most local neighbours. You can see there Kent, Surrey, Essex, Hampshire, and there's 3 SARCs in London as well. Next slide, please. So what we do, we're a forensic service which examines clients who have been raped or sexually assaulted, and we take forensic samples and we also check for injuries. We can give medication if necessary, and we will arrange for appropriate aftercare, and that could be sort of an assortment of things from counselling or ISVA support, which is independent sexual violence advisors to support somebody through their journey after their experience. So next slide, please. So in Sussex, we see anybody over the age of 14. Anybody under the age of 14 gets referred to a paediatric SARC, which is based in Brighton. Slightly different to some of our neighbouring SARCs in as much as they see anybody of any age, but for some reason, purely down to commissioning, that's how Sussex works at the moment. And what will happen is that a nurse will see any cases of people who are both sexually or non-sexually active. A majority purely based around the forensic element of what we do. A majority of the cases that we see will be here at the SARC. However, on occasion, we will outreach and go to people, excuse me, within the community, such as prisons, hospitals, care homes, that sort of thing. But as I say, where it's all possible, and from a forensic point of view, it's much better for individuals to come to us. Next slide, please. There's 2 ways of accessing the SARC. And quite a high majority of the referrals that we get come via the police. But we also encourage and promote the fact that people can self-refer to us. And what that means with the self-referral is that they'll go through exactly the same journey with us in terms of what we can provide them in terms of gathering forensic evidence and some aftercare services as well. And we will hold any forensic evidence that we find for a period of up to 2 years. And what we find is that by doing that, it sort of puts the ownership of the whole situation back to the individual, and they can feel quite empowered to have more control over the situation rather than coming to us via the police, where everything is quite full on at an early stage. What we do find, I mean, it's an ever fluid situation, but quite a high percentage of people who do come to us on a self-referral basis will at some point, and that might be the next day, the next week, the next month, or months down the line, will go on to report to the police. So we do find that, quite a powerful service that we provide, and we do encourage it if for whatever reason people are slightly apprehensive about going to the police in the first instance. Next slide, please. So in terms of who works here, again, this is very Sussex specific, but the same model really and truly does filter across, most SARCs up and down sort of the country. We have a SARC manager, and the likelihood of that, and this includes in Sussex, she's forensically trained, so she can act as a forensic nurse as well. But in addition to that, we have a team of forensic nurses. We also have a team of crisis and support workers, and we also have myself, a male outreach and crisis worker as well. So it's quite a small team, but yeah, all those roles, are very important in keeping the smooth running on a day-to-day basis of how we work. So next slide, please.
Okay.
Pass you over to Tricia.
So for us, for an examination, first of all, we want to make sure that we're happy with capacity. Under 16 would be making sure that the child is aware that they're fine to make decisions by themselves. Most of our children come in with a parent or an older person, but if they don't, if we're happy with capacity, then that's fine. In terms of capacity, the only times that we'd be hesitant perhaps is if they're under the influence of alcohol or drugs. In that case, we definitely should wait, because obviously capacity should improve once they're out of the system. Our consent form goes on and on. We take forensic samples, we look for injuries, but obviously we do other things like body mapping, we'll do images. Some people aren't very happy with that, especially younger people, so that's fine. So we just make sure that whatever they want to do, they absolutely can do, and get them to sign. We normally say as well, they can change their mind at any point. Just because you're signing doesn't mean that they have to do it. We take medical history, and we go into details of health since the assault. We ask the randomest questions. All of them have some significance, but I think sometimes for our patients that can be difficult to see. And we tend to set the scene. There's a lot of questions about alcohol and drugs, and we normally will talk then about consent with our patients. Quite often our patients' ability for consent for sex is impaired through alcohol, so we make that really clear. Lots of our patients really need to hear that. For ladies, obviously pregnancy testing, make sure we're happy before we do a speculum exam. And then we examine from top to toe is what we're supposed to do. Again, it depends on our patient. If they want a top to toe and they're happy with that, fine. However, in COVID times, some of our systems have changed, and so we'll do an awful lot of assessment on the telephone if it's appropriate. For children, I don't think it's appropriate, so they come in for a full face-to-face, but we try and limit the time they're exposed to us and the time that there's just any sort of exposure to each other's germs. So if we can do, we won't do a top-to-toe examination. Sometimes we will, especially if our patient has no recall. Injuries are photographed, documented on body maps, obviously with consent. We're very aware that anything we share with the police, potentially if it goes as far as court, that can be shared with everybody. So intimate images, so genitalia or breasts, don't get shared with the police, and an expert witness would come and look at our images at the SARC. And under 18s, we're supposed to have a look at their hymen on girls. So we would do slightly different things. We'll use a speculum again if the patient's happy, and if it's an anal exam, we'll use a proctoscope. Most of those would be videoed if the patient is happy. Forensic samples, we have a guide that changes every 6 months. It's from something called FFLM, a Faculty of Forensic Legal Medicine, and that's kind of our Bible. That guides us as to what we should do and when. And so we decide on samples. We're supposed to decide on that with the patient if they're a self-referral, or with the police. But normally they look a bit worried when we speak about stuff like that. So quite often we'll decide what we think is good, and then we'll hope to achieve that. Colposcope used for hymen examination, like I say, if they're under 18. And yeah, bottom line is the most important one. The patient will decide what they want to do. We'll say again and again, you know, feel in control in the SARC. If they don't want to do anything, that's absolutely fine with us. Next slide, please. And so in terms of the FFLM, so these are some of their guidelines. Forensic window. So some of them are really short. So 2 days in the mouth. We tend to find, especially if they come in by police, the police will have done some of the oral washings, they'll have done some of the swabs. 3 days in the anus, 7 days in the vagina, 7 days in cervix, 2 days on skin. And so they talk about digital. Digital obviously means if fingers have been used, it's 48 hours. And then we will take things like if they've had a tampon in, we would, if they're happy, we would exhibit that, condoms, pads, anything like that. We will keep anything they want to give us like that. Next window. Toxicology. This is relevant. Probably our rules are that if it's in COVID times, we're only supposed to take urine or blood if there's any evidence of DFSA. So DFSA is drug facilitated sexual assault. With drugs, obviously the most common drug is alcohol, so that obviously is a huge part of most of our patients' experience before seeing us. So yeah, there's just a really short window. The thing I always find really interesting about this is things will last far longer in urine. So if our patients just want to give us a urine sample, don't want a blood sample, that's absolutely fine. We find our younger patients don't want any blood sampling, and that can be something they're really quite anxious about. I think sometimes if they're police cases, they've been told what will be happening, as opposed to the fact that they'll have a choice about it. But yeah, that's what we do for toxicology, or that's what we're mindful for. And next slide. And then aftercare. So some of this is medication. So the first one is antivirals if we're worried that they have been exposed, or that there's an increased risk of exposure to HIV. And the window for that's very small, 72 hours. This tends to be the part where patients will be really upset if you've got to talk about the fact that you think PEP is a really good idea. Our patients will be really upset at this point. And if we start them on PEP, so we can start them on a 5-day course. The whole course is 28 days, but then it gets followed up with sexual health, and we'd facilitate that appointment also. Emergency contraception, we have two different types. One's 3 days, the other's 5 days, but we'll sort all of that out as well, just so it's a one-stop shop really. STI discussions, so we'll talk about low risk, high risk, and when they should go and get tested. We're really clear with our patients, our samples are forensic samples, they're not sexually transmitted disease samples. And then, as Rob mentioned earlier, we decide what referrals are appropriate. In Sussex, it's area-based. So East Sussex or West Sussex, they're both slightly different. We normally recommend that people should let us send a letter to the GP. It's not hugely factual, but if you've had to have a visit to a SARC, you're very definitely your GP who's responsible for your overall health should be aware that something like that's taken place. And sexual health, like I said, with most patients we'll say 2 weeks, but if we've started them on PEP, then we do an urgent appointment, and we've got fairly good relationships with our local GU services in Sussex. So we would send them some of the details and they would contact them. And then every client's offered a shower. That's a lie. It was true before COVID, but since COVID, again, we're not supposed to have patients here for any longer than necessary, which is a real shame. But we normally, there's a bag of toiletries that every patient gets given, obviously towels, gowns, Clothing and shoes, it's difficult. We go through our stock quite quickly, but that's it. And sometimes for aftercare, we find that our patients are so anxious about the examination that they're not really listening to us for this at all. So we tend to give them a booklet, and it tells them who they've seen, what we've discussed, who we're going to refer to, and what medication we've given and why, just so to sort of reinforce what we've done. Next slide. And referral. So this was what I was talking about. Sexual health, social services, all under 18, vulnerable, at risk. Yeah, also what I always find really interesting, was maybe not interesting to others, we sit in huge judgment sometimes, and so if somebody's been unlucky enough to be sexually assaulted or raped in their home and their children are safely in bed asleep, that's something that we information share. So that's something that we would do child safeguarding on. We make that really clear to our patients, especially if they're self-referrals, because obviously children's safety is paramount. But I sometimes think that's really harsh, children in bed and safe, but it's all for the greater good. School nurse, GP, health visitor, mental health, victim support. We also tend to find if they're under 18, the other thing we like is if they're under 16 especially, we would ask for a strategy meeting before they come see us to make sure that it's appropriate, or if they've got some sort of learning disability. I've been doing this now 6 years. I've never known them to say it's not appropriate. So I think it's a tick box exercise really, but they tend to have a formal strategy meeting after a child or anybody who's in care has been, and we normally would take part in that as well. Next slide. That's it.
All right.